Hello. We're going to get started with this workshop in just a second. As we're waiting for everyone to join, I'm going to ask you to take a look at the chat. We've put a couple file documents in there. One is called the Always Use Teach Back or AUTB Toolkit Tools, and another is called Making Teach Back and Always Event Planning. So if you can take a few minutes, a few seconds to download those documents and have them at hand, we'll be working with those during our session today. So it'd be nice for you to have them ready at that point in time. And then when you're finished with that, or simultaneously, go ahead and enter just in the chat who you are, where you're from, what your organization is, or the type of organization, and what your role, especially with respect to health literacy, is. And then your familiarity with the Always Use Teach Back Toolkit. And if we were in person together, it would be really nice to spend a few minutes going around and having people do those self-introductions themselves. However, with the virtual format, we'll make do with this and go ahead and have people at least begin to get a little acquainted by entering that in the chat. So take another couple seconds and then we'll go ahead and begin. Okay, so I'm going to go ahead and start. The presentation and workshop today is called Always Use Teach Back as a Centerpiece of Organizational Health Literacy. I'm Dr. Mary Ann Abrams. I'm an assistant professor of pediatrics at The Ohio State University College of Medicine and a primary care physician at Nationwide Children's Hospital in Columbus, Ohio. My work at Nationwide Children's focus and the College of Medicine focuses on health literacy, health equity, quality improvement, and medical education. I've probably been working in the field of health literacy for nearly 20 years or so. And my real focus is on real world implementation, especially with respect to organizational health literacy and behavior change, both improving the behavior of our health teams to make sure we use health literacy informed approaches and practices and skills and interventions, and also the behavior of organizations to help us offer information in a way that's easy and helpful for people to understand. I also do quite a bit of training and education in health literacy in the medical setting. So that includes medical students, faculty, and also adult learners, those who are learning to read as adults, and partnering with patients and families and the community population. So our workshop today, as I said earlier, it's virtual, but I hopefully will be as interactive as possible. We'll have the ability to weigh in on different things and share your thoughts and your experiences and ideas. And hopefully we'll all come away with a larger body of knowledge about how to advance organizational health literacy, and especially making use of the Always Use Teach Back Toolkit. So in keeping with the behavior change approach, just take a minute to tell us on a scale of 1 to 5 how confident you are that you can advance use of Teach Back in your organization, with 1 being not at all confident and 5 being very confident. And what we usually find is that people often start out earlier at the beginning of these workshops, moderately to fairly confident that they're comfortable using Teach Back and especially advancing its use in their organization. And sometimes that confidence level actually drops as they think through the complexities of, again, changing behavior, encouraging behavior change among our colleagues, the people that we work with for and help coach and lead in our organizational settings. So if we do this again, at the end, we may find that the confidence level may have gone down just a bit, which is probably a good sign that people are being more thoughtful and introspective about this work. So I want to go ahead and begin. You heard me mention involving patients and families in our partnership with adult learners with the voice of the patient. Ideally, we would have patients or adult learners or family members presenting with us at the same time, but there are other ways to share their stories with video and other approaches. So this is a very brief story that Norma, who is an adult learner in Iowa, shared about an experience that she had with her son. And this was a while back. He's an adult now and doing fine. But this is an example of her explaining an inadvertent medication overdose. And Norma is a woman who began to learn how to read in her 50s. And it took a while for her to discover that there were adult literacy programs, and she began taking classes as an adult, and she became an active member of the adult learners group, the New Readers of Iowa. So let's take a moment and listen to her describe this situation.
Well, he was on. The doctor says you.
Just going to restart it.
He had brain concussion. The doctor says you got a bruised brain. That's how he explained it to him, because that was a big word. I don't even know what it was, and it helped me too. He was going in and out of convulsions. I called the doctor. I did not understand. I was giving him, I think, 3 teaspoons 3 times a day, and he told me to give him 1 more teaspoon. Well, I thought he was 3 times a day, 1 more teaspoon. So I was giving him a tablespoon 3 times a day. The poor little thing was walking in the doors and the walls, and here was a chair, and he'd sit down over here. And I couldn't figure out what was wrong with him. So I called the doctor, and he says, bring him in. Well, he wasn't having no more convulsions. So I took him in, and he asked me, and I told him, and he says, no, just 1 more extra teaspoon. Oh, it was just a lack of communication, because I did not understand, and if I should have asked questions. But I didn't. Now I would have. But so wonder I didn't harm him worse than I did. But he's fine now.
Does it help you to say it in your own words? If I tell you something and then say, will you explain it back to me to make sure that I've done a good job?
Sure.
Is that helpful to you?
Yes.
Why?
Because it's there. I mean, when you say it, then you understand it.
Okay. After listening to what Norma just shared, I'd like you to go ahead and chat in your thoughts on these questions. What do you think about, we'll kind of run through them one at a time, Norma's perspective that she shared, the physician's approach during that telephone conversation with Norma, and then thinking about our own world and work environment, similar situations in our setting, and how this might be prevented. First of all, somebody says it's not unusual. What other thoughts about Norma's perspective? Norma thought she understood and did what she thought was right, helping her, it was her son, Close call or a near miss with a medication error, and it was almost a little bit more than a close call, wasn't it? Because he actually had some side effects that could have gotten worse. They're lucky, yes, Shelby. The physician assumed she understood, don't we all often? And even some of Jen, you're pointing out that even those who are highly educated can miss the point, misunderstand. And that's another good point, Stephanie. The physician does this all the time, so we know what we're saying, right? But expecting that patients understand is a mistake. What other things kind of struck you about what she said? Somebody brought up telehealth, which is so much more prominent now, right, than it used to be. So that's an even bigger opportunity for some disconnects in people's conversations. Do people here, she certainly was confused about teaspoons and tablespoons, wasn't she? Even when she was telling the story. And then 3 extra, was it 1 extra dose one time? Was she supposed to bump that dose up every time she gave it to her son? It's just fraught with opportunities, and her son did have a near miss, so to speak. And the other thing that struck me, I'm looking to see, she said, it's a wonder I didn't hurt him worse or hurt him more, but now I know. So she was assuming the blame, right? Like it was all my fault. And I would argue, and hopefully you would too. Yeah, Sean, I don't understand the dosage either. I would argue, and I hope you would too, that it's our burden, our responsibility for her to understand and to check for understanding when we're finished, right? And you might guess that by the name of this workshop, maybe Teach Back would be helpful. So just let's take a couple more seconds, chat in. What do you hope to accomplish or get out of this session about Teach Back and using Teach Back, whether it's for yourself or your organization or both? I'm interested to see what your thoughts are. You've been really great so far. What do you want to get out of this today? And then I hope we're going to accomplish it. Healthcare provider and team's responsibility. So how are we going to achieve that, right? Strategies to implement Teach Back and prove to clinicians how important it is. Okay, Devin, I hope we will tap that for you. I want to be an ally to healthcare workers in my system. Ways to ask people to teach back without seeming demeaning. I have a couple video examples of that. I hope that we'll have time to show those because I think that's a thing that concerned people raise. Best practices, help providers, new nurses, strategies, helping patients and providers to use it during their interactions. Great. Okay, well, let me go ahead and move more formally into some of the content today. So we have 3 basic objectives. One is hopefully, but when we're finished today, you will be able to describe how Teach Back and organizational health literacy are really key to safe, high quality, and equitable care. You'll be familiar with the components of the Always Use Teach Back toolkit, and we'll have a little time for you to actually plan some next steps to increase use of Teach Back in your setting. So we're going to start with kind of making the case, because what a lot of folks who work in the field know is they get it, they know, but they have to really make the case, whether it's to a manager or a senior leader or anywhere in between. So that first learning objective is what we're going to focus on for the beginning here. And I'm going to be doing some health literacy, I'm not going to say 101, maybe 202, not so much to just teach you health literacy basics, but to help you think through how you would use the data and the definitions and the key materials in the field to help make that case for you. So it's a little bit of a crosswalk between me talking about health literacy and you thinking about how you could apply this. So some of this will be very familiar. The technical definition of individual health literacy for years, it really did focus on the degree to which individual people have the ability to obtain, process, understand, and use basic health information and services to manage their health. And you've seen on several presenters so far today, the data from the National Assessment of Adult Literacy, the NAL data that was done in 2003, but we still use these data because they are the best and only health literacy data at a national level for the United States. And looking at other similar literacy assessments, not health literacy assessments, we don't really think that these numbers have changed much at all for the better, and potentially they could be a little bit worse for a variety of reasons. So there's a few important points, I think, for you to take away when you talk about these data. First, people ask now about the age of the data. I think it's really important for us to recognize that there's something unique about these. The health literacy, this is the only time health literacy was assessed, and it was assessed through tasks and questions as opposed to some of the things like the TOEFL and the realm. So we know, if you look at these graph depictions, the dark olive green is below basic, and the horizontal stripes are the basic areas of health literacy. The purple is intermediate, and the light green is proficient. So we know that a third of US adults have basic or below basic health literacy. About 50% have intermediate, and only 10% have what we call, about only 10%, 12% have what we call proficient health literacy. So this slice of the pie, this 10%, is really a centerpiece to painting this picture for your organizational leaders and others. The bottom line is that only about 10% of US adults have the health literacy skills that enable them to navigate our health system well. Goodness, well, we're done. I don't know how that happened. Okay, so let's move on to look at some of the subgroups. If you were in Dr. Coleman's presentation about an hour or two ago, you saw some similar data, but I think it's worth underscoring a couple other components of the NAL data. When you look at the data by age, we see that the risk for limited or low health literacy, same color legends, is much higher among those who are older. Nearly a half to 60, 2/3% fall into those risks of basic or below basic health literacy. Looking at it by race and ethnicity, we find that Black and Hispanic groups are at higher risk of having limited health literacy. And if you look at by type of insurance, those with Medicare, Medicaid, and no insurance also are at higher risk for limited health literacy. 50 to 60% fall in those groups. And those groups of people we know are more likely to have chronic diseases, health disparities, and need health care. And yet those are the groups that struggle the most with health literacy. It's important also to remember that limited health literacy does reflect that this is not something innate to those groups. It has to do with a lot of complex history and policies over the past, including systemic racism, poverty, social determinants of health, including less access to quality education, healthcare, and community resources. So it is important to not just paint that with a wide brush. We have good data that show, there's thousands of studies now, I think, that show that low health literacy is associated with a lot of less optimal, suboptimal health outcomes, less healthy behaviors, less use of preventive care, less knowledge of personal health, whether it's self-care for chronic conditions or other illnesses, understanding treatment choices, which really impact whether they can, they've received adequate, truly informed consent. A lot of potential for medication errors, poor ability to understand labels and health messages, increased utilization, more use of emergency care, hospitalization, and for some conditions and groups, increased mortality and poorer health outcomes. Yeah, I think you're talking about the PIAC, the Program for International Assessment of Adult Competency. Those are also literacy data. And I appreciate you bringing that up, Barry, because the PIAC reinforces the literacy, but boy, I wish we had the health literacy data too. Thanks. And then higher healthcare costs, which have been estimated at 1 to 200 billion. So I think when you're talking to leaders, you want to tap into what makes that organization tick. And there's a tremendous amount of work around quality, safety, and equity. And in the 2004 Institute of Medicine report on health literacy, one of their key findings was that health literacy is fundamental to quality care and explicitly relates to 3 of those 6 domains of quality: safety, patient-centered care, and equitable treatment. And also the other group of the IOM that talked about crossing the quality chasm actually prioritized self-management support and health literacy as cross-cutting priorities that need to be addressed to improve the overall health quality and disease prevention throughout the country. So recognized not as the only solution, but cross-cutting applies to all dimensions of healthcare to improve quality, safety, and equity. I think it's also useful, a lot of folks talk about the triple aim, the IHI triple aim, or the quadruple aim now, which is another framework for quality. And I think we can think about how does health literacy impact each of those dimensions. So the triple aim involves pursuing all 3 of these areas: improving the patient experience of care, which is quality, satisfaction, improving the health of populations overall, and reducing costs. So moving a little bit more into the safety realm, the Agency for Healthcare Research and Quality defines patient safety as freedom from accidental or preventable injuries that are caused by medical care. Therefore, practices or interventions that improve patient care are those that reduce the occurrence of these preventable adverse events. And health literacy would fall into to those domains. And the Joint Commission stated that the safety of patients cannot be assured without mitigating the negative effects of low health literacy and ineffective communications. And the National Quality Forum endorses teach-back and reader-friendly materials as fundamental and necessary for informed consent to reduce harm. So there's this precedent by highly visible, credible organizations that health literacy is necessary to these areas as well. So we recognize now that health literacy is not just an individual trait, but it's the product of those individuals' capacities and the demands that we in the health system place on people in our complex settings. So that when we want to address health literacy, that means that we have to improve the skills of the system as in how we communicate with people, not just expect them to meet us where we are. That led to the development of the 10 attributes of health literate healthcare organizations. Again, that was led by Cindy Brock and other members of the Institute of Medicine Roundtable on Health Literacy. And we could have a whole discussion about those. But this is another area for you to spend some time thinking about. How do you want to think about these attributes and how do you integrate your teach-back work with those? So those attributes include leadership, that make it a priority, that helps integrate it into planning, evaluation, safety, and quality. So it's not just a one-off project that's one and done. How to create a shame-free care environment that meets the needs of patients, regardless of their health literacy level. Looking at access to health information services and navigation support. And this, again, one of the important areas that you'll be focusing on, no doubt, is preparing the workforce so that they can be part of this health literate organization. Using health literacy strategies and interpersonal communication to ensure and check understanding. That's why we're here today. Especially focusing these efforts on high risk points, whether it's a care transition, discharge, medication change. Including consumers and end users up front, not just developing something and saying, don't you just love this, but including them in the design, implementation, and evaluation as partners. Obviously, people always think about print materials, written materials. We have to think about social media and web design as well to make sure the information there is easy to read, understand, and act on, and then to communicate health insurance and costs as clearly as possible. So the exciting thing is that in last year, when Healthy People 2030 was released, it was finally officially elevating health literacy, especially within the concept of health equity. So Healthy People 2030 that sets goals for the country and drives research and funding and policy stated and included health literacy as one of within their overarching goal, that we cannot eliminate health disparities or achieve equity. Well, the goal is to eliminate disparities, achieve equity, and attain health literacy to improve health for all. It's also among their foundational principles that says achieving these things requires eliminating disparities and attaining health literacy. They tweaked the definition of personal or individual health literacy just a tad, but they developed this new definition of organizational health literacy as the degree to which organizations equitably, and the emphasis again is on equity, enable individuals to find, understand, and use information and services. So together, these two definitions have a new framework and a new description of what health literacy means. And it's starting to shift people's perspective, or in our setting, it's sort of creating these ahas that, oh, we're never going to really help to, it'll take a long time to improve the health literacy of all these individuals, but we can start to meet people where they are and improve the way we provide, deliver, and ask for information. Just a real quick slide to point out the Enliven is one self-assessment that can be used to look at those 10 attributes. And it's got a lot of sub-points within those 10 attributes that could be a useful tool as you try to look at that within your organization. So that sort of wraps up this beginning, making the case. Take a second, and Brandon, if you could set up this next poll. I know that you might be saying, let's work in all areas. It was supposed to be a number poll, not a typed poll, but go ahead and just enter a couple where you think among those choices, where you might work. Safety, Sean, thanks. Education. Oh, you're going for 2, Sean, great, 1 and 4. Okay, Brandon, you want to go ahead and see where we're landing on this? I don't know if people are going to type in the word or type in numbers. Okay. Okay, this is a perfect example. You can close the poll of how I should have done teach back when I asked the person to set my poll up. I had hoped that they would make it a pick one, 2, 3, or 4 or 5, and they didn't. But we're getting a lot of education and safety. How about some quality and health and equity? Thank you. Okay. This is more to prompt you to start thinking than to, to get the right number or the right answer. It helps you to kind of start thinking what's going on in our organization where I can seek alignment with health literacy and teach back and ensuring clarity. Oh, okay, great, Magdalena. Whoops, no, Judy, good for you. And Jean, great, all right. Okay, so now hopefully you've kind of built some confidence and ideas for how you might talk about this in your own organization. And then hopefully they're going to say, well, okay, now what? So what are some solutions that we can offer, and then try to tie those to what's going on, or what area or what project or what initiative you might be able to join with. I'm going to just go ahead and show these 2 videos. Again, not so much to teach you about all this right now, but to give you a sense of how you might use something like this when you're trying to engage to prepare your workforce. So hopefully this will work.
So Nolan, like we talked about, you have exercise-induced asthma which means you have bronchospasm, and it's an inflammatory process as well. And I'm going to give you this inhaler that will help you feel a lot better before you do gym or biking or things like that. It's very easy to use. I'm sure a smart guy like you will be able to figure it out. Basically, you take the inhaler, you stick it in the spacer, pop the spacer cap off, put your mouth on it. And that's it. Give yourself 2 puffs, but do them one at a time. And then you can do that 15 to 30 minutes before you're going to do strenuous exercise. And that will take care of all that inflammation and bronchospasm that's going to occur as part of your exercise-induced asthma. Okay? I'll send this to the pharmacy for you, the prescription for both the spacer and the inhaler. And then we'll see you for your physical exam next year. Questions about anything?
No.
It's great to see you. Have a good year. Don't be afraid to call if you do have any questions.
Okay.
See you guys.
See you. Thanks. I have no idea.
Okay, so it was a little quiet, but what did we see? So you guys were already chiming in. Very fast jargon. This kid knows what bronchospasm is? Yeah, right. Should have let the boy teach it back, perhaps. Didn't use open-ended questions. Questions about anything. And they look so overwhelmed, technical. So it's a nice way to try to have something similar to this to get people, because clearly Dr. Cheney in this video, he's a nice guy. He has rapport with these patients. He's clearly not wanting to be a good doctor with them. But what we saw was the kind of the way people are used to doing this. I think you've hit most of these. Technical terms, jargon, too much information, too fast, yes, no questions. And at the end of the day, we saw totally lack of understanding. And yes, Tan, you pointed out, calling him a smart boy would make him hesitant to ask questions. And I had not picked up on that the first few times I used this video, and people pointed that out to me. And I think that's a really good point. Just like maybe some of us as health providers don't feel comfortable asking questions when we're, picking up a prescription or in a physician's office, maybe with a family member or even for ourselves. So what? You got the prescription and they had their visit. What can happen? They got in and out. Dr. Cheney's moving on to the next patient. Anything? Anybody see anything wrong with that? What's the problem with that besides that they looked a little confused? He could have an asthma attack, right? Not coming across as empathetic, poor use of the medication, not using it right. So he won't know how, so he may not use it at all, right? And it leaves a lot more chance that the asthma, the inhaler may not be used, not knowing when to use it. And his mother was lost, so she couldn't help, end up in the ED, may quit sports, good point. Okay, so potential for medication error, and then we blame lack of compliance or lack of adherence. Poor self-management, maybe afraid to do anything because he wasn't sure and could it hurt if I did it wrong, or overuse or underuse, ending up coming back to the doctor's office or the urgent care or the ER, maybe in the hospital. And don't forget about things like missed school and work, right? That's a big deal. So mom or dad has to leave work, he misses school, and ultimately his asthma is poorly controlled. Thank you, as Maritza pointed out. And not getting physical activity, if that's what triggers his exercise-induced asthma. So what can we do? Well, that's why we're here today, right? We talked about health literacy, universal precautions, use of plain language in both verbal and written communication. And at the end of the day, we have to make sure people understand, because otherwise, why did we bother with anything else if they don't know what they need to know or do? And we can do that by hopefully teach back. So it's important to think about universal communications principles or the universal precautions approach, because, and this is another point that you want to drive home, clear communication helps everyone. You can't tell by looking at somebody whether they understand or don't. Maybe if they have kind of a dazed look in their eye, but for the most part, you know, somebody looking at one of us probably isn't going to know whether we understand, especially if we're a little hesitant and we're nodding and saying, no, I don't think I have any questions. And even if we do have high health literacy, depending on the circumstances, anybody can have trouble. If we're sick, if our child is sick, if we're worried, if we're preoccupied, if we're on pain medications, if we have been up all night with a sick child or ill ourselves or got a bad diagnosis, there's a lot of reasons why people may not remember or understand. So the recommendations are to use clear communication words and tools for everyone. What does that mean? It means always using plain language, slow down, short statements, 2 or 3 most important things, the need to know versus nice to know, which is, I find that myself still hard because there's so much good stuff to know, but really we have to keep that in mind, and then to check for understanding. Plain language is clear. This is what plain language is. It is not dumbing down. Please join me in trying to eradicate that term when people talk about using plain language. It uses the words that you need to communicate this message. It's not baby talk. It lets people focus on the message instead of the complex words. And it also does not mean that there's not a role for the technical information that we use to talk among ourselves as providers. What I try to think about it as is we need to become bilingual and fluent in moving back and forth between our technical terminology and our plain language to basically interpret for patients and with practice and skill that can become second nature. But it's hard. We go to school for a long time to learn this, and then we need to go back and translate or interpret that. So what is Teach Back? I'm sure you're familiar with this, but I think it's important to recognize that there's several important elements of Teach Back. Not just asking people to explain it back, but to ask them to explain it back in their own words. So that's one of the key points. And to do that in a friendly way, to make sure that doesn't come across as a test of the patient, but a measure of how well you explained something or how well I did to make sure I was clear. And it's a way to check understanding. And don't forget that if they don't quite get it right, re-explain a little bit differently and then check again. So the standard way of asking for Teach Back is, I want to be sure I explained everything well. Can you tell me in your own words what you'll do so I can be sure I was clear? But clearly you're not going to use that over and over again. There's different ways to think about Teach Back and to incorporate it into interactions with patients depending on the setting. So asking them what they'll tell someone else. What will you tell your daycare provider or her grandmother about how to give a DT her medicines? Think about it in terms of behavior change and action plans for chronic conditions or improving a health behavior. So we've gone over a lot of information, a lot of ways you can work on getting more sleep. In your own words, can you go over what we talked about and how are you going to make that work for you at home? So you're kind of asking them to kind of summarize, to prioritize, and to think through, well, what steps am I going to take to get to bed earlier, or turn off the TV earlier, or whatever. And then think about how you want to incorporate that into things like follow-up calls or telehealth, and shifting away from this, do you have your follow-up appointment scheduled, but moving it to please tell me when your next appointment is. How are you handling your pain, not do you have any pain? Because it's too easy for people to say yes or no to those questions. So those are forms of Teach Back. And don't forget, it's not just the nurse or the educator or the doctor's job, it's everyone on the team. And that means clinical and non-clinical. So it's registration desk, it can be billing, it can be, pharmacies, social work, etc. So please tell me when your appointment for your next COVID vaccine is. Let's make sure the paperwork gets handled right. Can you tell me what you'll do with these forms? I want to be sure I did a good job showing you how to find the labs. Can you tell me how you're going to what you're going to look for on the way there. We want to be sure you understand what your insurance will and will not cover. Can you go over it in your own words? This will help me make sure that I explained it well. So there's these other little pieces that contribute to using TeachBack well. If you have more than one topic, we use the thing called chunk and check, meaning you teach 2 or 3 main points for the first topic, check for understanding before you go on to the next topic, as opposed to one gigantic TeachBack at the end. You want to support your teaching and discussion with reader-friendly materials. And really, you can use TeachBack all the time, but you really want to drill down and think about what are those key things, key education, key communication, key points in the healthcare continuum where it's most important. And if you're able to, with electronic medical records or other systems, document your use of and how well patients are able to respond to TeachBack, and you can use that to gather data over time to see how that system is performing. And I've got an example of that later on. If people can't TeachBack, think twice or 3 times what else might be needed. Do they need a hearing aid or hear better with their glasses or some other device? Ask if they want to include a family member or a friend. Clearly, and make sure you're working with interpreters if they're a language. Think about other literacy or cultural barriers. You can invite someone else to help, but you don't have to just stay there forever. I think the fear of taking up too much time is always concerning to people. So you can schedule a follow-up visit or a follow-up call. And if somebody is really struggling and they have a complex healthcare situation, you want to pass that along so that they maybe get some extra help or navigator help as they move through the healthcare system. There's a lot of research, and I am highlighting just a few for a variety of reasons. Sort of the seminal present paper was by Dean Schillinger a while back called Closing the Loop, but that demonstrated improved outcomes among adult diabetic patients with diabetes in the outpatient setting when physicians use TeachBack. There was a paper by Fink in the Annals of Surgery. They had a standardized computer-based consent program, and they built in a repeat back or a TeachBack to that, and they had improved comprehension when they evaluated that. Press looked at hospitalized adults who had either asthma or COPD, and TeachBack, when it was used, was associated with fewer acute care events in the 30 days after discharge, especially among those with lower health literacy. They also found that their use of their meter dose inhaler improved after education, but that effect waned. And there's a couple other studies too that suggest this need for ongoing reinforcement, but there were some improved outcomes there. Griffey looked at adults who were discharged from the ED, and when they used TeachBack, they found improved understanding of their medications and self-care and follow-up instructions. Volrath looked at, this was a study looking at, it was a QI project where they included a standardized teaching approach that incorporated TeachBack to improve feeding safety and parental comfort with understanding their discharge instructions. And a study a couple of years back, a meta-analysis looking at hospital to home transitions, where there were several specific interventions, ensuring follow-up care, discharge planning, TeachBack education before they left, and other planning that they talked about incorporating into a discharge improvement bundle. So this concept of it should be part, it applies to all of these things, and it needs to be woven into the process, standard processes. So one of the biggest concerns always is time, right? And I see somebody referencing that in the chat. Sean, thank you. So it does take a little more time. So in the Schillinger study that was for diabetes management in an outpatient setting, the average was 1.8 minutes more in the visits that used TeachBack. So if you multiply that times 30 patients a day, that's an extra hour, right? In the Fink study that dealt with consent, it took about 2.5 minutes more. Now, I would argue that maybe another 2 to 3 minutes when you're talking about informed consent for surgery is not an inappropriate addition to that time. And the press article, it took 4 minutes more. But the interesting thing was that the teaching was done by the respiratory therapist. What a great adjunct to build into their role and to have them use TeachBack. So there's ways to work as a team to incorporate TeachBack into care. And then to shift how people think about it. There are trade-offs, you know, there's interruptions. Mrs. Smith called back because she doesn't understand what she's supposed to do with her medicine. Or Mrs. Smith is back in a month and she's no better because she didn't understand how to use her inhaler. And so she thought it was best just to wait and see what happens. So kind of looking at the overall balance of these trade-offs. The other thing is building it into your workflow, your practice, your habits. It becomes just part of how you do it, and it shifts sometimes how you explain things once you realize, oh gosh, people just aren't understanding it when I explain it this way. So I've improved how I'm explaining it. And Cindy Brock, who's also at ARC, talks about how physicians report that when they do these little mini teachbacks throughout a visit, that it becomes more manageable from their perspective. And at the end of the day, this provides the opportunity to further improve health outcomes, which again is why we are at work and doing this work every day. And Jen, thank you. The time can help build trust between providers and patients as well.
So Nolan, now that I showed you how to do it, I'd like you to show me how you.
So I'm gonna start this over. I want to make sure you can hear it. I don't know why these volume things go down. This is just an example of asking for TeachBack.
So Nolan, now that I showed you how to do it, I'd like you to show me how you're going to do it before practice to make sure that I didn't forget anything when I taught you. So I'm going to give it to you just like the pharmacist is going to give it to you. And I want you to just show me how you would use it before practice.
All right. I think this is called the inhaler.
So I'm going to, for the purposes of time, I wanted to focus on how he asked for TeachBack. Nolan does not teach it back correctly. And what you see, I hope what you saw is that Dr. Cheney in this video, he did take responsibility for being clear. He sat down, he established more rapport, a more relational tone of voice and body language, and then he asked the patient to explain it back.
So you got this part right. Okay, so the first thing.
So now he's going to re-explain and then ask again.
To do is to stand up. Okay.
All right.
Let put this in the spacer. Okay. Let your air out. Okay. Go ahead. So the key things that I would do is I would only take one puff at a time. Okay.
Oh, okay.
And I would do it 15 to 30 minutes before exercise. Okay, so 15 to 30 minutes. So the good thing about that is like before gym class, that's probably why you're changing your clothes, or, you know, you could use it before you went out for band practice, for marching band, that kind of stuff. So it doesn't have to be right before. And you do 2 puffs, but you do 1 puff at a time to let it all get down to the bottom of your lungs and let it last, you know, or let about a minute pass between. Okay. And that really should last for a long time, so you shouldn't have to do it again.
All right.
Okay? So why don't you go ahead and show me that again, okay?
All right.
So what I like there is if we'd watched the whole first one again, you see how he shifted how he explained it in slightly different ways and words. He took responsibility for for Nolan mixing it up the first time. He re-explained. He kind of separated it into those 2 key content messages, the timing and the inhaler, gave examples, and then he asked again for TeachBack. And again, I think in a very unthreatening, non-threatening way.
You put the inhaler inside of the spacer right here, and then you put your mouth on it and make sure that your tongue's under it and it's all around it. And you squeeze it once, about 15 to 30 minutes before you do any exercise. And then wait about a minute and stand up when you inhale it. And then after that minute, squeeze another puff. And so then you'll be good to go for that whole exercise time.
That was really good. I think you have it. Do you have any questions about it?
No, I think I understand it now.
Do you have any questions at all, Mom? I have this great handout that I'm going to give you. I've highlighted the parts that really show how to use the inhaler. And sometimes if you keep this right by your inhaler and you look at it the first couple of times, that will help. Okay, there you go.
So again, just to wrap up, he was able to teach back the second time. And then he asked for additional questions of the patient as well as the parent, and then supported that with a handout that he marked up, circled the key information, and reinforced the learning. So that's sort of a successful approach to using teach-back in the clinical setting. Carol, I see your question about time. I don't know that we can say that teach-back does not add time. I think that might be just, a promise that we don't necessarily keep. I think what we learn, I tried to show that with those 3 studies that have quantified the additional time, that we need to make the argument that it is so important to the quality, the equity, the safety, that we need to figure out how to do this together. And you want to look at your team, not just making one person have to deal with it, and try to illustrate why it's so important. Health educators, etc. So I'm going to move on just for the sake of time. One of the things I'm kind of highlighting is the Always Use Teach Back Toolkit. And why is it called that? That sounds kind of funny, right? Again, it comes from the safety literature. So the Agency of Healthcare Research and Quality and others define a never event in healthcare as an adverse event that is clearly unambiguous, serious, and usually preventable, and it should never happen. A death, surgery on the wrong limb, IV potassium, things like that. So the counterpoint that was offered out of the Institute for Healthcare Improvement a few years back are always events that are aspects of the patient experience and care that are so important to families and patients that we must perform them consistently for every patient, every time when they're indicated. And that is the underpinning of why this is called the Always Use Teach Back Toolkit, because the goal of it is to make the use of Teach Back when it's appropriate and indicated an always event throughout the care continuum. And the focus, especially on this toolkit, is especially during transitions within settings or between settings. So the toolkit has, an explanation of how to use it, an interactive learning module, coaching support tools, and it's a tool that you can use in your organization. You can use it as an individual. There are tools that it describes how to use that if you're just saying, I really want to get better at doing this. Or if you're someone who's supervising or leading or managing, it describes how to use those coaching tools to help others to improve their use of Teach Back. The learning module is really a core kind of basic module that covers what Teach Back is and why we use it, what are the key elements, what are non-shaming questions to elicit Teach Back. Again, that's a concern a lot of people have, and some illustrations of how to integrate it into clinical encounters. So you can assign this, you can use the toolkit for your employees, your staff, your colleagues, yourself, and it's in the public domain. Just a few illustrations. It covers Teach Back at hospital discharge, home health, and then in the outpatient follow-up setting. It includes the tools, the 10 elements for using Teach Back effectively, coaching tools with some videos, how to overcome obstacles, how to coach a nurse or a physician, and then the tips, coaching tips, the observation tool, a confidence and conviction scale, and some examples of how you can weave Teach Back into standard procedures to make it an always event. So the confidence and conviction scale is based on behavior change and Francesca and DiClementi's work and Rolnick about how to look at what might be needed to move this confidence forward or to increase the frequency of using Teach Back, or which elements one needs to work on in particular. And the observation tool parallels the 10 elements of using Teach Back effectively. The coaching tips are here. And these are examples of how TeachBack was integrated into pneumonia standards of care or clinical competency assessment order sets and discharge order sets. So I'd like to go ahead, and I was going to do a breakout session for about 8 minutes. See if I can figure this out. I might do the breakouts for just 5 minutes. If do I have the ability to do that, Brandon?
Yes, ma'am, you do.
I'm looking for it. Do I see it here?
It should pop up now.
In the more section?
If you look
Breakout,
under
I
that
got
tab,
it,
you
I
see
got it.
you should see breakouts.
I got it. I got it. Thank you. What do we have, about 50 people?
It's 135 people.
Oh, wow. I thought it was capped at 60. Well, that is a lot of breakout rooms. Okay. All right. I am going to ask you to go into a breakout room in just a moment. Hopefully you can find the PDF with all the tools, and ask you to look at those tools and think about how you might use them in your setting. And I will, as soon as I create the breakout rules, I will load that back into there it is. Thank you, Brandon. All right, so grab grab the tools, and then I'm just going to give you like 5 minutes so that we have enough time to move through the end of the session. Okay, I think we're good. Any questions? People back, breakout rooms closing. Brandon, are they closed?
No, give me 1 second.
You'll close them?
Yes.
Okay, looks like I'm getting a message. Most people are back, wish they had more time. And so you feel like most people are back?
Not yet, give me 1 second.
You'll tell me?
Yes, ma'am.
Well, I love it when people say there wasn't enough time, and I'm very sad also, but it sounds like there was some really good discussion in several of the breakout rooms. And I also saw a couple questions posed and a couple comments, but I'm going to circle back to those as we enter in the last third of the discussion.
Everyone should be back in.
Okay, great. All right. Feel free to chat in anything. I see some people have already chatted something in. What tool you thought might be the most helpful, or if you thought of how it might align with something that you're working on or people are working on in your organization. But I'm going to go ahead and move on so that we have enough time. Okay, let's see here. So now we want to talk about how to increase use of teach-back in your setting, which is what a couple of those comments were that I just saw. So thinking about moving, changing people's behavior over time. So there's our usual methods, right? We have noon conferences, lunch and learns, trainings, education, but here are some additional tips to help with that. Oh, I love what I'm seeing here. Making it personal. Even though we've got all these good studies and national data, you need to look for and elicit, find, seek, encourage experiences in your setting so that people know, yes, we experienced that here in our setting. And sometimes it takes a nudge from you to kind of share a personal observation of an experience that you saw in your setting. But making it personal and connecting it to your organization, your leader, who is responsible for all these components of managing the organization. Stories, as we know during COVID, are very powerful. You only want to tell true stories, but stories are incredibly powerful. And then don't just finish up, but have a call to action. What can you do by next Tuesday? And not like by next month, next year, or you're going to make a group to plan. But how can you have somebody take even a small step? Could you try using this plain language handout one time in tomorrow's clinic? Would you be willing to try using teach-back with your last patient tomorrow? That kind of helps mitigate that fear of too much time. Or could you ask a family member for feedback to help improve a form? And then we might be able to learn from some of our colleagues that do marketing and promotions. So they plan their interactions with us. So they think ahead, they talk about the benefits, and they ask questions to kind of get the person that you want to start using teach-back thinking. How do you feel when people don't keep their appointments? Where do you see yourself using teach-back? Where could it be most helpful in your practice or your setting or your unit? How do you see yourself maybe using this reader-friendly handout with patients? And think of objections as good things. It means they're interested enough to at least listen and think about it. As we saw, if you saw Dr. Coleman's comment, sometimes reflective listening, restating it, clarify, seek to understand, validate their concern, support your point, and address what the specific thing is that's concerning them. And then close again. Would you be willing to use this, or willing to think about it, or willing to try it? And then agree to circle back. Can I check back with you in a week or two to see how it's going? And then some of the coaching tips, building motivation and honoring what they're already doing very passionately, very well, and working hard. So it's not like we're saying you're not doing it well, you've got to change. It's like you are doing great work. We want to make it even better. Recognize, as we've said, that changing is hard. We have our patterns, our habits, resistance is natural. And then you want to support the new development of these skills and help them feel confident to build this into their practice patterns and habits or work patterns, so that it becomes second nature, just like a lot of the other things we do that we've developed over time. Build reliability and supports, make it part of the standard work with reminders and prompts, make it the default. And then expect that not everybody's going to do it all the time, or they may fall out of the habit. Do some relapse management, follow up with coaching, have problem-solving sessions, and then highlight people who are doing a good job or come up with a good idea. Think about it when people are struggling, like, I just don't think I can do this, but listen to them, evaluate their concerns, explore their ambivalence. That's an interesting point. Tell me more. What makes you say that? Maybe I didn't say that right. What makes you say that? What makes you think that, or ask that question? That's a really good point. And then think specifically, if they have a different perspective, you want to understand, acknowledge that, address the importance, and then inspire them to sort of grow beyond that or extend beyond that. If they have other things going on, you validate that and try to work together to problem solve, because you can't really tell somebody how to change their clinic or their rounding or their however their call management to try to solve that, but to work together to do that. And if there are barriers, maybe you can identify one specific one and focus on what you can do to figure out how to improve that. So someone asked, Carol, you commented how it takes 17 to 20 years to bring new research and new data into practice. And you're right, those studies were done in Iowa, actually. But we also know that the model for improvement and small tests of change and plan, do, study, act cycles are an effective vehicle to accelerate adoption of new behaviors and change. And you heard me talk a little bit about those questions. Can you see yourself trying this with one patient at the end of the afternoon? So don't be afraid to test it one time, or ask someone to test it one time, one patient, maybe one doctor who's kind of an early adopter willing to try it, one office, one facility, and also to scale back. We think so much about, well, next quarter or next month. When you're testing things, just say, we're going to try it tomorrow afternoon. We're going to do it one time tomorrow afternoon, or we're going to try it on Thursday, or we're going to try it next week. The power of soon, because what that does is lets you test it, work out the bugs before you grow too broad. And if it goes well, you've boosted confidence and someone's more willing to try it again and extend that. Well, maybe I'll try it all tomorrow afternoon, or they'll talk to their colleagues about it. So don't be afraid to try these small tests of change. And what might that look like? So Dr. S is going to try using TeachBack with the last patient. She thinks it's going to be really uncomfortable and it's going to take way too much time. So she did try it with a patient, a parent. The mom was a 38-year-old teacher, and her child was in, and the parent, when they were asked to teach back, they mixed up the change in the medications, and then Dr. S was able to correctly explain the change in the medicines. Well, when she studied it and thought about it, Dr. S was surprised that a teacher, of all people, mixed up this simple change in the medication, and she was relieved that she had been able to re-explain it. And it wasn't so bad after all, asking the parent to explain this in her own words, and it didn't take so much extra time, and the parent was so much more comfortable she could read that body language. So now Dr. S is going to try it with 5 more patients or parents who have other conditions and may not be teachers. She's going to kind of keep track of her time and her own and how the patients feel. and how many times it takes her to teach back if she has to keep repeating. So that's an example of how you might do a small test of change. And then you can ramp up and do more and expand. This was a quality project several years back where they used Teach Back on inpatient med-surg units. And as you can see, they achieved a centerline shift from about 30 to 40% up to about 60%. So that's still a good improvement. And you might think about a QI project where Teach Back can be incorporated, or that even focuses on Teach Back. And here's some of these other, some ideas for where you can align your health literacy and Teach Back work. Clearly, we talked about quality and safety, disparities and equity, all the discharge work that we're doing to reduce readmissions, and that we all are dealing with portals and phone calls. Don't forget that USMLE, the US Medical Licensing Authorities, the Joint Commission, CMS, they care about health literacy. And it can also be a risk management approach to risk management, because if people don't understand and there's an adverse outcome, that puts the organization at risk. And it clearly fits with training and education, whether it's undergrad, graduate medical education, nursing, pharmacy, physical, social work, physical, occupational, or speech therapy. There's a lot of competencies around those. And then there's higher level things. Accountable care organizations, they incur financial risk based on the health of the population, even if they're not in our doors. So communicating effectively to help people be healthier is important for them. And then there's, as you probably know, financial incentives in the Affordable Care Act, especially to reduce unplanned readmissions, chronic disease management improvement, care transitions, medical home, and HCAHPS, patient satisfaction and experience data. All those have financial impacts on organizations, and those should matter to some of your leaders that are in your setting. And then how do you make it stick? So build it in. I saw some of these things kind of going by before. Position descriptions and performance reviews, make clear communication and effective use of Teach Back part of that. I saw orientation and credentialing go by. Obviously training and education, order sets, building it into care processes. Don't wait to the last minute. Discharges are crazy time anyway, so start early. And then here's an example of a couple places where we had built it into our EMR. Was the patient or family able to teach back? Yes or no, partially, or maybe they weren't asked to do so because things were just too crazy or I forgot. So you want to give people a little bit of a way out. So think about your quality leaders, your safety leaders, putting it on those agendas, thinking about some metrics that might belong on a performance scorecard, identifying communication, patient-provider communication related adverse events. Make sure your faculty teach, model, and evaluate with their learners use of Teach Back. Recognize those who are leaders and do it well. Involve patients and families and end users in materials development, because it makes it so much more eye-opening because we're used to this language. And then engage in the community and teaching them how to elicit Teach Back. Just a minute, this is what I heard you say. I want to make sure I understand. That's a sort of strategy that you can approach with patients. And that everybody on the team knows when and how to access trained health interpreters and how to work with them, can pass along the need for clearer communication when it's important that it follows the patient throughout the hospital. And again, from a safety perspective, they can stop the line. They can say, I don't think Mrs. Smith understands what is going to happen when she goes home, or they don't understand the risks and the benefits of this procedure. So it may be someone who's bringing their dinner tray that people are more comfortable talking in front of, who hears this family conversation, but they are authorized and expected to go to the nursing station and say, I think someone needs to speak to the patient. They don't seem to understand. And that everybody uses Teach Back where appropriate and starts to think about, well, gosh, what are the health literacy implications of this? This sign, is this really clear? If we give people this handout or we make this complex registration process, is that really user-friendly. So we're winding down. I'd like you to take about 2 minutes because I'd like to build in a little time for you to think about next steps. The document, the planning document is in the chat, and maybe Brandon, you can bring that again to the front. I tried to put it and make it a Word document, but it just wouldn't load. I'll try again. But take 2 minutes. I'm going to set the timer and think about what you want to do or accomplish when you return home, so to speak. And then what steps and how you're going to share your plan. And then we're going to come back and we're hopefully going to effectively share our ideas. So 2 minutes is starting. Brandon, someone said the microphone isn't clear at my end. Is it still a problem?
No, ma'am.
Okay. Okay. Now, I see some good comments in the chat, but I'm going to try to do this effort to share. And I do apologize about the guidance on the breakout session. The slide wasn't showing when I was getting the breakout set up and I got off task. So I would like for you to go ahead and click either on the link here or use the QR code. And then we're going to kind of get a chance, hopefully if this works well, see what others are thinking. Are you good with this? I can also try to put it in the, yes, I can post the link on the chat. I have to go out of the, Lynn, you can speak, if you don't mind, can I get this set to go first? Okay, I am really, really hoping that someone is going to tell me that they are seeing the Mentimeter screen that people are filling in.
I'm seeing it fine.
Okay, great. Thank you. And hopefully you'll see, maybe gather some additional ideas from people. And this will start to scroll as more people join. Lynn, go ahead if you wanted to add something.
Yes, I was going to say the Centers for Medicare and Medicaid is currently soliciting input from people, from hospitals, if you are with a hospital, on measures that should be collected to ensure equitable care. So I think some of these measures might be a really good idea. I know that some of our groups within the hospital collect, like, what we call social determinants of health, but it's not in the electronic health record where you can actually pull and search for it. So we collect it on our own databases. And we were told that if it's billable, then it's in that EHR. But if it's not billable, so this might be an opportunity to make a suggestion to CMS about maybe we should start collecting some of these data. I like that the question that you had about, was the patient given teach back or
what was the patient able to teach back? Yes, no,
yes.
Partially. Yeah, and once you have it in the EMR, you can track it, right? And then you can track it by location. You can try to emphasize it, and you might want to just start with one floor or one service, neurosurge or a high risk thing, or maybe not. The neurosurgeons are pretty busy. Maybe you want to find a place where you think you've got some early adopters, but without the data, it's hard to know, right? So yeah, is there like a chat link that you could put in here in the chat? Okay, so I love what we're seeing, and I know we have like 3 minutes. And I think this gets summarized, and maybe we can send that out to everybody too. So the strategy, get on the grand rounds, encourage teach back with discharge instructions, training new and existing staff. I think too, getting on with onboarding. And the other thing about leaders, I saw several comments in the chat about that too, that think about what is your organization or your department, what is their key mission or vision or strategic plan, and then think consciously about how does making sure clear communication, how does it fit with that, and how does teach back in plain language, clear communication fit with that? Because it's clear you can't carry out your goals without people understanding. All right, I'm going to stop sharing the Mentimeter and go back to my last set of slides, or my last slide. Because I think we are just about finished. All right, one more quick poll. Brandon, is everybody going to be gone, like just cut off in 1 minute? Or can we do this poll?
No, I actually got word that we're fine going just a little bit over time since we're the last session.
Okay, I'm not going to keep you too long, but it'd be nice if we could kind of wrap up this is the second to last slide. If you want to launch that poll, it's the same question you answered when you first started. How confident are you that you can advance use of TeachBack in your organization? We're kind of topping out at 2/3 of the people responding. I'm going to give it 5 more seconds and then close it up and show the results. Or do I do that?
Results should be showing now.
Okay, great. So it looks like we shifted a little bit to the right. I think we had a bell curve that went from 1 to 5 before, with 3 being the highest level of confidence. And now we're closer to 4, and we've moved some people, nobody's on 1, and we've moved from 2 to 5. So hopefully we've provided some ideas and tools and thoughts about how you can move Teach Back forward in your organization. And Myra, you said earlier, I saw your name in the chat, and you said you're currently using Teach Back with very good outcomes. Do you want to tell us a little bit more about that?
Yes, I work for the University of Puerto Rico School of Pharmacy, and our students, part of the curriculum is to introduce during the first year the Teach Back methods. So pharmacists since first year can apply the knowledge and skills and how to use Teach Back during patient counseling interventions. We also have some kind of interprofessional interventions with the students from the School of Medicine and Dental Medicine, and we practice the Teach Back interventions, and so they learn and they enhance their experiences. Another thing is if they're people, when they are going back to work, they allow them to do it. But I have several very good experiences, especially with small clinics that negotiate with health insurance, and they are allowed to do what it's supposed to be, as well as pharmacies, special or specialized pharmacies.
Great, thank you so much for sharing that. And I think you're absolutely right that if we can integrate it into professional training and then move it all the way through, and then really I think another important point is getting the faculty all on board so that when they go out into the real world practice, they continue to see it modeled and used. But thank you. Go ahead.
As you mentioned, as part of a marketing strategy, we should work with the health insurance in order to negotiate some kind of, space to do what we need to do and explain them the benefits.
And it sounds like indirectly or directly, some of what Lynn was talking about with CMS is an opportunity to do that as well. So thank you. Well, we're over time. I really appreciate people who stayed all the way to the end. I appreciate all the great input in the chat. I did my best to kind of keep an eye on that while we were moving forward. That will be saved, right, Brandon?
Yes, everything should be saved.
Okay. All right. Are there any last questions, or should we go ahead and let you, those who are on the East Coast are probably ready to wind up their day, maybe not everywhere, but any last thoughts? The toolkit is not available in languages other than English. That's a really good question. We'll have to think about that. Thank you. Well, thank all of you. I really appreciate your questions and your participation. I wish we were physically together, but this hopefully helped foster conversation, dialogue, gave you a little time to think about what you're going to work on when you get back to the office. And I'd love to hear from you to to see where we go. I was going to put my thing back up. There's my email. All right. Thank you, everybody. Have a great day.